In Uganda, the quality of healthcare service provision is less than desirable and remains depressing at large. Limited service delivery, inadequate funding, gross staffing gaps, and few medical equipment, among other factors, remain a big challenge in an effort to implement Ugandan National Minimum Healthcare Package, which focuses on health promotion through disease prevention, maternal and child health, nutrition, prevention, management and control of communicable diseases, prevention, management and control of non-communicable diseases. Healthcare is one of the key responsibilities that was decentralized. This ensured that local governments within the districts and sub-counties took charge. Yet, there has not been appropriate distribution of resources to the local governments to support this function. The reality of inadequate financing and skilled personnel is more at display in Kamuli district, located in eastern Uganda, about 100 kilometers from Kampala. With a population of approximately 450,000 people, Kamuli faces several challenges in its provision of health services.
Since time immemorial, the planning figures have been the same for districts, and we realize that villages are growing every day, the catchment areas are becoming bigger, so the funding is also a big problem. So we can't even try to maintain a few basic things like our ambulances. We can't maintain them on the roads because we have better priorities to deal with.
And actually, this budget things have changed. The budget in fuel was 1,500, but currently we find diesel is 3,500. The money has not changed, the prices have changed, and the quantity has gone so low.
Like many other districts, all ambulances that were used by health centers have broken down, with no hopes of being repaired. Kamuli Hospital, which serves more than 400 patients in a day, is faced by acute shortage of staff. This, for instance, has meant that the X-ray department has remained unused since the hospital was opened as a full district hospital in 2007.
This place has not been working since the hospital was opened. This is an X-ray machine. This one is an ultrasound machine. But they have never got a staff, a radiographer. The district have advertised several times also have not got a radiographer who can work on these machines. And the vacancy here, a radiographer is for a U5. Yet when we get people who apply for this job are people with a bachelor degree. This is of recent put up in Makerere. So these people are supposed to begin with a U4, not a U5.
So when you look at service delivery across the board of the district in terms of specific services to be rendered, you find there are deficiencies. Like operations can't take place, the mothers who are delivering in these health centers cannot be operated because there are no medical doctors.
Our staffing level is at 49% compared to the national standard that should be at least 65%. So already that's already a big gap. And we all know that even if we had health facilities, even if we had ambulances, even if we had all these other things, drugs, but without the personnel to actually deliver the service, we can't really do much.
Despite the improved delivery system by national medical stores, stockouts of drugs still persist in most health centers due to the push system. The demand is clearly more than the supply.
It is not enough for the cycle because by the time they bring those drugs, we are almost out of stock for at least 3 weeks, especially anti-malarials.
This district is lucky to have a number of partners working with us. I'll just highlight a few. We have Strides for Family Health, which really deals in reproductive health and child services. This is one of the major ones. Then we also have Star EC, which is also helping us with strengthening HIV and TB practices in the district. These are both USAID funded district technical based organizations. Then we have SDS, which is strengthening the district sustainability.
STAR EC, in partnership with United States Agency for International Development, helped equip Kamuli Hospital and other health centers with various equipment which were lacking. Today, they have come together for a performance review meeting which evaluates activities being implemented in more than 5 sub-counties. Namunyonji Health Center 2 was constructed by Plan Uganda and handed over to the local government. It serves a population of about 4,700 within a radius of 2 kilometers.
Bwetulwala tulida ndaba era abasawo babaawo era baatukolako libaawo lyonna ery'obulwaire bw'obanga obuli kuluma.
Kamuli village health teams, which are managed by the Village Health Committee, have been active in community mobilization and empowerment for health action deep in the village.
Our work is mainly to mobilize people in the village, tell them about health. We sensitize them about immunization. We mobilize them to go and immunize their children.
Here it is also worse when mothers start getting the labor pains. They end up delivering in their homes. They end up delivering traditional birth attendants.
Health officials and administrators still believe that much needs to be done to change misperceptions, beliefs and practices which are mainly caused due to high illiteracy rates that has resulted to poor health-seeking behavior by the people in the community.
You have a sub-county where the people are refusing to go for immunization. For them, religion, they have a religion in Kamuli which tells them immunization is not religious.
But the struggles within the health sector in Kamuli are not restricted to this district. They are reflective of the general conditions in the country. Take, for instance, Busia district, located in southeastern part of Uganda, north of Lake Victoria, and west of the Republic of Kenya. With a rapidly growing population of more than 500,000, and total fertility rate is 7.1 births per woman. This border town is faced by numerous unrelenting challenges in providing health services. A persistent funding gap is impeding the delivery of health services in Busia. The health services in the district rely 100% on primary healthcare conditional grants, which has remained stagnant for the past 5 years.
MASAF is one of the least funded hospitals in the country. But if you look at our operational costs, like water, like electricity, like maintenance of this infrastructure, maintenance even on the area of infection control and maybe cleanliness, we are so constrained.
The monies at times we allocate based on our revenue base is not sufficient. It's little.
The health workers are paid through the PHC wage grant. If it is not increased, we can't recruit, we can't promote.
Busia district staffing norm for health workers is 512. But currently, the district has only 214, which is 41% of the staffing level. MASAF General Hospital has 72 health workers out of the required number of 185. Currently, the General Hospital has only 1 medical doctor out of the required 8. This shortage of health workers makes those available to work for long hours in order to provide services to a huge number of patients.
Especially on the critical cadre, like medical officers, it's a big challenge. Currently, I'm the only doctor here, and that means a lot of work.
Sibona Health Center 2 serves a population of approximately 7,000 but has been operating without a midwife. Hence, most of the deliveries are always referred to Buhehe Health Center 3, which is 10 kilometers away.
We have the maternity here. It is not operating because of no midwife here. For antenatal, we handle them, and at 32 weeks we refer them to health center 3.
Kira ni munyala wade maternity ward batuberesa enga siri ko operatinga nani wakasabire mwa government yatamu mani maternity ward yanjo hola sino yanjo ko operatinga mwa tufunira nende musawo ahola ho aho babu.
High disease burden in the district has amplified the demand for drugs, which ran out of stock within 3 weeks of being delivered by national medical stores.
Actually, since July last year, at the beginning of this current financial year, we ran out of the chemicals. Now we made the orders and we were able to receive only one type of chemical, the fixer. But the developer has never been supplied since then.
We have not had stock out of the anti-malarials. Those ones are adequate. And then the antibiotics, they are the ones which are supplied in little quantities, and those ones we normally have the stock outs. And then because of the push system, there are some drugs which are also brought for, which do not treat some of the common conditions.
The disease burden is so big that you need more resources. And some of those resources are those medicines and drugs, as they used to be called, and they are not enough.
In every health center, there is acute shortage of staff houses, with many of the health workers traveling long distances from their homes to where they work. This also impacts on service delivery for those medical staff on the evening and night shift, who have to travel late in the day when it is dark and unsafe.
To make matters worse, being based in a rural setting, you will not find rental units easily within Masaf here. So many of our staff stay in Busia town, which is 8 kilometers away from here.
Even though new staff houses are being constructed at Busitema Health Center too, the old dilapidated staff houses need urgent renovation.
The situation in housing is really very poor, where a normal person cannot even stay in.
In order to lessen some of the constraints the district is facing, there is an integration of Masaf General Hospital and lower-level health unit services, such as mobility of health workers between the hospital and lower-level units, and sharing of drugs whenever necessary. The district has embraced the usage of radio talk shows, drama, and film shows to put emphasis on prevention.
But in all this, there are behaviors which make people have bad health. So my department is basically to organize IEC materials to empower them with information which is targeted to them changing behaviors, either to seek for treatment early or to remain healthy.
Partnership between the district local government and NGOs such as World Vision, Intergovernmental Area Development, IGAD, and Child Fund has seen improvement in infrastructure such as staff houses. Ministry of Health funded a new ultra-modern theatre which will see much-needed surgical procedures being carried out in Busia. Uganda Local Governments Association, ULGA, an umbrella body for all the local governments, has been at the forefront of advocating and coordinating delivery of better health services. They have carried out research and organized dialogues that focus on various aspects across all sectors. Most recently, under the health sector, ULGA brought together all district chairpersons and district health officers to discuss, among others, the critical issue of financing for immunization. There is a general consensus among all stakeholders that more emphasis in the national budget should be focused on financing health, which is core to the development of the nation.
NMS has made serious improvement, especially timeliness of delivery. And also there is some degree of improved level of communication that we can get updates on what is happening. But the few items that are missing really constrain service delivery.
If the PHC can only support 4 radio talk shows, that's quite minimal. If you are to go to the field, the whole district, you can imagine, you just can't go probably only twice in a month or twice in a quarter and think you've done something very good.
They should increase on their salary. Because they are the people who cater for our lives. Minus them, we may not live. Because each and every day a person is sick. And I may be moving like this, but my health is bad. Where am I going to end?
To be able to see an increased funding to Ministry of Health, we should be able to see increased funding to districts to address health issues. We are talking of the Millennium Development Goals, maternal health, child mortality rates. They can only improve if there is increased funding. And those of us who are working must also have a positive attitude